Hi everyone, welcome to Raw Online Teaching Program. I am Dr. Monica, your pediatric faculty. So in today's session, we are going to see about the standard treatment guidelines given by the Indian Academy of Pediatrics. So far there are almost like 90 standard treatment guidelines have been there in the IAP website. So this series of lectures is going to be just quickly we are going to revise all those guidelines. So in that neonatology there are almost like 8 to 9 treatment guidelines have been presented so far. So today we are going to see about the neonatal hypoglycemia. So hypoglycemia is one of the most common metabolic problems seen in the sick babies. So if you see initial hours of life, the blood glucose will be on a lower side compared to the normal values of older children. What happens in healthy infants after the initiation of the breastfeeding, this low glucose level will slowly manage to become normal blood glucose levels. So most of cases this neonatal hypoglycemia are very transient and they usually respond between 2 to 3 hours of life. Only if the neonatal hypoglycemia persists more than 3 to 4 hours of life, then only we need to intervene. So if you see asymptomatic hypoglycemia, in the initial 4 hours of life, it will be only around 25 milligrams per deciliter, but the baby will be asymptomatic. As soon as you start the breastfeeding, this blood sugar, like low blood sugar, will respond and go to the normal values. So in between 4 to 24 hours of life, it may be around 35 milligrams per deciliter, and between 1 to 2 days, it will be around 45 milligram per deciliter, and after 48 hours, if you see, the blood glucose will always be maintained around 50 to 60 milligrams per deciliter. So this neonatal hypoglycemia doesn't require much treatment. Usually it has an excellent prognosis. Whereas in symptomatic hypoglycemia, where there is like the hypoglycemia blood sugar levels are persistently less than 50 milligrams per deciliter, then they are associated with a high risk of severe neurodisability. So babies with persistent low sugars, then we have to investigate for the underlying causes. So if you see whom to investigate. So testing is warranted only for at-risk neonates and it is not needed for all the healthy term newborns. So usually the testing is done by using a reagent strip, which is very easy, like bedside, convenient, and it is also cost effective. But the only drawback is this blood glucose which is measured by the strip is 15% lesser than the plasma glucose level. So when you are noticing low blood glucose level in the CBG, at the same time you have to send the lab sample for the blood glucose estimation, which is the confirmatory for the hypoglycemia. And for each hour delay in testing the sample, the blood glucose will fall by 6 milligram per deciliter. So as soon as you collect the sample, you have to send to the laboratory for the plasma glucose estimation. So this is regarding whom to test the blood sugar levels. So moving on to the etiology of neonatal hypoglycemia, the most common cause for neonatal hypoglycemia is hyperinsulinemia. This is the most common cause for neonatal hypoglycemia. And whereas other common causes are decreased production or decreased stores, or there is increased utilization of blood glucose. So these are the causes of neonatal hypoglycemia, of which hyperinsulinemia is the most common cause. So if you see in hyperinsulinemia, the most commonly it is seen in the infant of diabetic mothers. So where the hypoglycemia is persistent and it is also recurrent, it also prevents the utilization of secondary fuel sources, like it decreases the fatty acid synthesis and ketone body formation. So thereby it prevents the utilization of secondary fuel sources also. So this is the main mechanism behind the neonatal hypoglycemia caused by hyperinsulinemia, of which the most common cause is seen in the infant of diabetic mothers, where the hypoglycemia is persistent and also recurrent. So, if you see decreased production or decreased stores of glucose will be there in generally preterm babies, IUGR or small for gestational age babies. And increased utilization, most probably it occurs due to perinatal stress factors. Like perinatal stress factors includes birth asphyxia, neonatal hypothermia, shock, or in case of sepsis, or in case of post resuscitation. So, in all these factors which causes perinatal stress, there is increased utilization of peripheral glucose. So, thereby it leads to neonatal hypoglycemia. So, one more extra point in this etiology of hypoglycemia you should learn is congenital hyperinsulinemia. Maybe they can ask you in OSCEs or in case of entrance examination, they can ask about congenital hyperinsulinemia, where the mutation is noted in the ABCC8 and KCNJ11 gene mutation, where there is the pancreatic beta cell adenosine triphosphate sensitive potassium channel which encodes for the protein SUR1 and KIR 6.2. So, SUR1 and KIR 6.2 June. So, this causes elevated insulin levels that is associated with a loss of function mutation. So, maybe this gene that involves the mutation in congenital hyperinsulinemia, they can be asked in the OSCEs. So, this is regarding the etiology of neonatal hypoglycemia. So, most commonly you should not forget about this hyperinsulinemia in infant of diabetic mothers. So, moving on to the diagnosis. So, diagnosis is basically done by checking the plasma blood glucose level, which is the confirmatory for hypoglycemia. So, symptoms in general, if you see, they are very non-specific. Like neonatal hypoglycemia, the child may be irritable, there may be tremors, jitteriness or exaggerated morose reflex. The child may have high-pitched cry. Sometimes hypoglycemia will result in seizures. The child will be lethargic, hypotonic, cyanosis, apnea and poor feeding. So, these are all very non-specific which may occur in many other conditions also. So, in neonatal hypoglycemia, after checking the CBG, you have to confirm it with the plasma blood glucose levels. Then, even after, then you have to intervene with IV glucose. Then you have to recheck frequently. So, when the hypoglycemia does not respond to the IV glucose, or when the glucose infusion rate is keep on increasing, like for example, if you will be starting with 5 to 8 milligrams per kg per minute of GIR, but when it slowly increases the requirement, then you have to see like something more than the cause for this neonatal hypoglycemia. So, you have to extend your investigations. So, that extension of investigations apart from the plasma blood glucose levels in the context of neonatal hypoglycemia is called as a critical lab sample. So, critical lab sample includes first glucose that we will be checking frequently, and the second level of the blood sample is in checking the insulin levels. So, when the GIR increases more than 10 to 12 milligrams per kg per minute, that is the glucose infusion rate increases more than 10 to 12 milligrams per kg per minute, or the neonatal hypoglycemia is persistent for more than 72 hours, then it is considered that we need to investigate further on this hypoglycemia. So, the second tier of investigation is checking for the levels of insulin levels. Even now, even the insulin levels are normal. Then what we will be doing? We will be going for the third tier of investigations. So, these are the third tier of investigations when the insulin levels are normal, because we will be expecting the hyperinsulinemia. So, insulin levels are increased. But if the insulin levels are also normal, then you have to go for the third level of investigations, that includes growth hormone, ACTH hormones, thyroid and thyroid stimulating hormones, glucagon, plasma amino acids, and urine for reducing substance, urine for ketones, amino acids and all those things you will be checking. And as already discussed, a rare cause of congenital hyperinsulinemia, so genetic testing for mutations like SUR and KIR can be done. So this is regarding the third level of investigation for neonatal hypoglycemia evaluation. So coming to the management part, as you all know, mainly for transient neonatal hypoglycemia, which itself will resolve in another 2 to 3 days. Main thing is you have to provide skin to skin care, you have to keep the baby warm and promote the breastfeeding in the initial, like as soon as possible. And infants should continue the breastfeeding on cues, and you should not give any extra water or glucose water or formula feeds, because that may interfere with the normal metabolic compensatory mechanisms. So in another thing, at risk infants who are also symptomatic and their blood glucose is less than 40 milligram per deciliter, then you have to start with a IV glucose. So this IV glucose less than 40 milligram per deciliter, straight away you will be starting with the GIR of 5 to 8 milligram per kg per minute. If the blood glucose is still low, that is less than 25 milligram per deciliter, first you have to prep with a bolus dose of IV dextrose, that is 1 to 2 ml per kg, then you have to follow by GIR of 5 to 8 milligram per kg per minute. So what are the targets you will keep? The blood glucose should be more than 50 milligram per deciliter. At the same time, you have to continue the breastfeeding frequently and keep on rechecking the blood plasma glucose every 30 minutes. So if a child is asymptomatic but still the blood glucose seems to be less than 40 milligram per deciliter and only that my baby is only less than 4 hours of age, then as previously described, we have to start the breastfeeding, initiate the breastfeeding and promote frequent breastfeeds and recheck blood glucose before every feeding, continue to give skin to skin contact and intensify the breastfeeding, and at the same time evaluate for the underlying causes. So if the blood glucose levels is less than 35 milligram per deciliter, then this is the time you have to start with the IV glucose, even the child is asymptomatic. And the target blood glucose should be always kept more than 50. Target blood glucose should be always kept more than 50 milligram per deciliter and recheck until you get the 3 normal values. So you have to keep on rechecking until you get the 3 normal values. Then check the blood glucose once at 24 hours of age in babies with the small for gestational age or low birth weight or preterm babies, because they are at risk of neonatal hypoglycemia. So this is regarding the management of neonatal hypoglycemia. So this is the parenteral therapy, that is the glucose rate calculator. So here is the how much volume of fluid that has to be given, that is ml per kg per day, and how much GIR should be infused, which is given as milligram per kg per minute, and the glucose percentage. So this is calculated by the formula. GIR is dextrose percentage concentration into how much volume, that is ml per kg per day divided by 144. Like for example, if an infant is receiving the 10% dextrose, for example, if you keep 10% dextrose water solution, the infant is getting, and the volume is 80 ml per kg per day. So for example, if you keep like this, so the GIR is calculated as percentage of dextrose concentration, that is 10 into 80 ml per kg per day divided by 144. So the GIR is around 5.6 milligram per kg per minute. So this is how we calculate the glucose infusion rate. So this is regarding the management. Further workup is, as already said, in infants with the persistent hypoglycemia, when the blood sugar levels are persistently low, that is less than 40 milligram per deciliter, and which is persisting more than 72 hours, and GIR keep on increasing to 10 to 12 milligram per kg per minute. So these are the indications where you need to follow it up with the second and third level of investigations. So this glucose infusion, your maximum dextrose concentration through the peripheral IV cannula and the central venous catheter is only 10 to 12 milligram per kg per minute. That's why we have kept this as the target. So regarding the first level of management, like providing the glucose therapy for neonatal hypoglycemia, I have discussed. Some extra edge points regarding this neonatal hypoglycemia, the main point of reference taken from the Clougherty Manual of Neonatal Care. So, if you see the other drugs, when the neonatal hypoglycemia persistent for more than 72 hours, then they may help with the drugs like hydrocortisone, which is given as IV dose, approximately 10 to 15 milligram per kg per day. So, what this hydrocortisone actually does is actually increases the gluconeogenesis. The mechanism is gluconeogenesis, and at the same time it decreases the peripheral utilization of the glucose levels. And before giving the IV hydrocortisone, you have to draw the blood for the blood cortisol levels before starting the treatment. So, baseline blood cortisol levels should be measured, then only you have to start with the IV hydrocortisone therapy. So, second drug that can be given is diazoxide. So, they may be asking about, apart from IV glucose, what are all the drugs that are used to treat the neonatal hypoglycemia. So, you may be knowing to write at least 3 to 4 drugs. So, one is IV hydrocortisone, second is diazoxide, again it is around 10 to 15 milligrams per kg per day. So, this diazoxide, actually the side effect is mainly fluid retention. So, while prescribing the diazoxide, it has to be prescribed along with thiazide diuretics. So, main side effect is fluid retention. So, you have to prescribe along with the thiazide diuretics. And the third group of drugs that can be used for neonatal hypoglycemia are octreotide, which is the somatostatin analog, and this is used to decrease the insulin secretion. So, insulin secretion is itself decreased by using octreotide, and the dose is almost 5 to 20 micrograms per kg per day. So, this is regarding the third level of medicine which is used for neonatal hypoglycemia. Very rarely glucagon is used. That too, if the glycogen stores seems to be normal, then you can those babies may benefit with glucagon injections. And further, maybe you can investigate by using L-fluoro and F-fluoro and L-dopa PET scan. So, this scan is done to look for any focus lesions in the pancreas. So that these babies may benefit with a subtotal pancreatectomy. So, these are all not very common things. Just for the academic purpose, we are just dealing with these slides. So, if you see, apart from the IV glucose, IV hydrocortisone, diazoxide, octreotide, and further the investigation is the F-fluoro L-dopa PET scan, which is able to localize the lesions in the pancreas. So, those babies may benefit with a subtotal pancreatectomy. So, these are all certain extra points in the management of neonatal hypoglycemia. So, coming to the long term follow up and evaluation, you see neonatal hypoglycemia, it has a strong impact on the visuomotor problems, poor executive function, low literacy rates, and low level of numeracy. So, infants with the hypoglycemia, they have been reported to exhibit a typical pattern of CNS injury, mainly in the parieto-occipital cortex and subcortical white matter. So, however, it is difficult to differentiate whether it is only isolated hypoglycemia or hypoglycemia is one of the complication in the underlying hypoxic ischemic encephalopathy. So, it is very difficult to differentiate the CNS pattern of injury where it has been affected, and depends upon the recovery phase only we will be able to identify only it is an isolated problem or it is a complication of some other underlying disease. So, this is the short session regarding the neonatal hypoglycemia. Thank you.